Welcome back to my channel. And today we're going to go through myocarditis and focusing on the most important things you need to know. Myocarditis means there is inflammation of the myocardium. And since myocarditis and pericarditis can overlap, there is a term called inflammatory myopericardial syndrome, IMPS. And we use it until a final diagnosis of either myocarditis or pericarditis is established. If the picture leans more towards pericarditis, we call it myopericarditis. And if it leans more towards myocarditis with some pericardial involvement, then we call it perimyocarditis. When it comes to the causes of myocarditis, we can divide them into two groups, infectious and non-infectious causes. Infectious causes include viruses, bacteria, parasites, and fungi. Viruses are the most common infectious cause, and examples include coronavirus, adenovirus, enteroviruses like Coxsackie B virus, also parvovirus B19, influenza, Epstein-Barr virus, HIV, and human herpes virus 6. Bacterial causes include Borrelia burgdorferi, causing Lyme disease, and the group A beta hemolytic streptococcus, which is associated with acute rheumatic fever. Parasitic causes include Trypanosoma cruzi, which is associated with Chagas disease. Non-infectious causes include autoimmune diseases such as systemic lupus erythematosus, systemic sclerosis, and cardiac sarcoidosis. There are also genetic disorders and drug-related causes, for example, penicillins, and lastly, cardiotoxins such as alcohol and cocaine. All of these can cause myocarditis. Next, the clinical manifestations. We can classify myocarditis by duration. Acute myocarditis is symptoms for 4 weeks or less. Subacute myocarditis is symptoms lasting from 1 to 3 months. And chronic myocarditis is symptoms lasting more than 3 months. Fulminant myocarditis is the severe form and presents with hemodynamic instability and cardiogenic shock. Patients can also present with arrhythmias, which are mainly ventricular arrhythmias. Ventricular arrhythmias are arrhythmias with broad curious complex, which is more than 120 milliseconds on ECG. The symptoms can be palpitations, syncope, or in severe cases, it can be sudden cardiac death. Atrioventricular blocks can also occur in myocarditis, so let's go through them quickly. In first degree AV block, the PR interval is prolonged. You can check the purple arrows below. And then in second degree Mobitz type 1, the PR interval progressively lengthens until a curious complex is dropped. In second degree Mobitz type 2, the PR interval stays constant and then suddenly a curious complex is dropped. And in third degree AV block, there is complete AV dissociation. P waves are independent of curious complexes, so the atria and ventricles are no longer synchronized. And myocarditis can present with a new onset heart failure or worsening heart failure. So you always want to check the left ventricular function, and you do that by checking the left ventricular ejection fraction on the echocardiography. Clinically, chest pain is the most common presentation. Patients can have ST elevations and elevated troponin, so it can mimic ST elevation myocardial infarction. The chest pain can be sharp or dull, and it can radiate to the arms, neck, or jaw. Many patients also report a viral respiratory or gastrointestinal infection before symptoms start. Other symptoms include dyspnea, which means shortness of breath, and it happens especially with physical exertion and exercise. Other symptoms include tiredness and weakness, fever with flu-like symptoms such as sore throat, chills, cough, and also muscle and joint pain. We also need to recognize high-risk patients because in these cases, we should consider an endomyocardial biopsy. High-risk features include acute heart failure, cardiogenic shock, cardiac arrest or syncope, ventricular arrhythmias such as sustained ventricular tachycardia or ventricular fibrillation, second or third degree AV block, or imaging showing a new diagnosis with left ventricular ejection fraction being under 40%. For the diagnosis, we start by taking history and also doing physical examination. And we also ask about any recent respiratory or gastrointestinal infections in the last 4 weeks. Also, we ask about family history. And we need to rule out coronary artery disease. And if it's suspected, we can rule it out with either CT coronary angiography or invasive coronary angiography. It depends on the likelihood of having coronary artery disease in that particular patient. We can do ECG, and on ECG, we can see ST and T wave changes, specific changes. Also, we can see AV blocks or ventricular arrhythmias. Chest X-ray can be taken, and it can show cardiomegaly, and it also help us rule out pulmonary involvement. We need to check biomarkers like troponin and NT-proBNP, which is a biomarker of heart failure, and also CRP, which is an inflammatory biomarker. And we can also consider doing genetic testing if there is a family history or the patient is having a severe ventricular arrhythmia or if there is a recurrent myocarditis. Transthoracic echo is used to assess chamber size, ventricular function, wall thickness, and ejection fraction. Cardiac MRI can help us assess the extent of injury if there is edema, ischemia, or necrosis. And endomyocardial biopsy is considered in high-risk patients, which we talked about in the earlier slides. These are the patients who present with hemodynamic instability. And also we can consider doing endomyocardial biopsy in patients who are not responding to initial therapy. Diagnosis is confirmed when the clinical picture fits, and either cardiac MRI or an endomyocardial biopsy shows evidence of myocardial inflammation. In cardiac MRI, using the Lake-Lewis criteria, myocarditis is supported when there is myocardial edema and a non-ischemic pattern of myocardial injury. With endomyocardial biopsy, we can assess for necrosis, inflammation, or fibrosis and identify the inflammatory cell type, for example, T lymphocytes or macrophages. Also, if an infectious cause is suspected, PCR-based testing can be done on the biopsy samples. RT-PCR for RNA viruses like Coxsackie-B virus, and PCR for DNA viruses such as parvovirus B19, human herpes virus 6, and Epstein-Barr virus. PCR can also be used to look for Borrelia DNA if Lyme disease is suspected. Additional supportive findings include ST changes on the ECG, also troponin elevation, and on echocardiography, we see wall motion abnormalities and reduced ejection fraction. Additional testing include a nasopharyngeal swab with the PCR for COVID-19, influenza, adenovirus, and enterovirus. Also, we can look for antibodies of HIV, hepatitis B virus, hepatitis C virus, Epstein-Barr virus, cytomegalovirus, and parvovirus B19 in the blood. Also, we can check for Lyme antibodies in the serum. And if we're suspecting an autoimmune disease, we can check autoantibodies such as ANA. Management of myocarditis includes the use of anti-inflammatory drugs such as NSAIDs, for example, ibuprofen or indomethacin, or aspirin plus colchicine. If an autoimmune or drug-induced condition is suspected, then we can give corticosteroids such as prednisone or methylprednisolone. We also need to discontinue the causative drug immediately if we have drug-induced conditions suspected. And if there is no effect with the glucocorticoids, we can consider adding immunosuppressants such as azathioprine or mycophenolate mofetil. If the patient has heart failure symptoms, then we can treat it with heart failure therapy, for example, beta blockers, ACE inhibitors. And if there is congestion, then we can also diuretics. Antibiotics are used if Lyme disease is suspected. For example, doxycycline can be given. And in viral myocarditis, the benefit of antivirals is not yet established. Lastly, if Chagas disease is suspected, we can give an anti-trypanosomal drug called benzimidazole, and it can be given in a mild disease. Fulminant myocarditis is treated like cardiogenic shock. We start with inotropes such as dobutamine, or or we can also add vasopressors such as norepinephrine. If there is inadequate response, we can escalate to mechanical circulatory support, such as veno-arterial extracorporeal membrane oxygenation, ECMO. And if ECMO is inadequate, then we can escalate further to an intra-aortic balloon pump. General about myocarditis, we advise the patient to limit physical activity until biomarkers CRP, troponin, and the proBNP normalized and the patient is no longer symptomatic. Around 1 month is recommended for the patients. For secondary prevention, an ICD, implantable cardioverter defibrillator, can be used to prevent sudden cardiac death in non-acute myocarditis and in patients who have sustained ventricular tachycardia, which causes hemodynamic instability. That's it for today. I hope you learned something useful about myocarditis from this video. If you found it helpful, please like and subscribe so more people can see it, and see you in the next videos.